Hello, my name is Asia Takeuchi, and I will be taking you through an introduction to renal ultrasound. We will start by discussing the indications for renal ultrasound, then move on to machine setup and patient positioning. From there, we will review the different views you will want to obtain and compare normal anatomy to some examples of common renal pathology. The most common indication for performing an ultrasound of the kidney and/or bladder in the emergency department are suprapubic flank or groin pain, hematuria, AKI, and decreased urinary output. However, it is important to keep in mind that any time you are considering a renal source for symptoms, you should be thinking about AAA as well. And remember, a negative scan does not definitively exclude the possibility of ureteral stone. Let's move on to setup. For this study, you will want to use a low-frequency probe for better depth penetration, so either a phased array or curvilinear. While the curvilinear may be more helpful in a larger habitus patient, a phased array may fit better between the patient's ribs. Your exam type should be set to abdominal or renal if available. Have the patient lie either supine or in the lateral decubitus position. To help maneuver around the ribs, you may ask them to rest their arm above their heads or take a deep inhalation or exhalation to see if this improves your view. Let's start our exam on the right. Your approach for this slide will be to place the probe in the right lower intercostal space in the mid-axillary line. Using the liver as your acoustic window, aim the probe slightly posteriorly. For the long axis view, you will start with the marker dot pointed towards the patient's head and then fan anterior to posterior, or belly to back. To switch to the transverse view, you will rotate 90 degrees from the long axis and then fan from the superior to inferior pole of the kidney, or head to toe. Placing the probe as instructed on the prior slide, this will be your position on the patient. To minimize rib shadow, it may be necessary to rotate the probe to a slightly oblique position to account for the oblique lie of the kidney. Fanning anterior to posterior will give you a complete longitudinal evaluation of the organ. As you can see, the outer cortex of the kidney is somewhat hypoechoic when compared to the liver. Moving deeper, you will see the triangular pyramids that are even more hypoechoic than the cortex, or may even appear anechoic. At the center of the kidney is the renal pelvis, which appears as bright hyperechoic space, brighter because of the increased amount of fat in that area. We will now switch to the short axis and be sure to fan from the superior to inferior pole of the kidney. We will now move our exam to the left. For this side, you will place the probe in the lower intercostal space on the posterior axillary line, more cephalad and posterior than when visualizing the right kidney. Again, for the long axis view, you will start with the marker dot pointed towards the patient's head, fanning anterior to posterior. For the transverse view, rotate 90 degrees from the long axis and then fan from the superior to inferior pole of the kidney. In this transverse view, you can see that each kidney is surrounded by tough, fibrous tissue, the renal capsule, which itself is surrounded by perinephric fat, renal fascia, and paranephric fat. Normal adult kidneys measure approximately 9 to 12 centimeters in length, 4 to 6 centimeters in width, and 4 centimeters in thickness. The left kidney is commonly longer than the right, however, there should be no more than 2 centimeter difference in the length between the two. The renal arteries run retroperitoneally from the aorta to the renal hila. They lay deep from an anterior approach and are often partially obscured by bowel, making them difficult to see well. However, when visualized, spectral waveform may be used to assess the peak velocity and resistance index to search for evidence of renal pathology, such as renal artery stenosis or acute tubular necrosis. However, this is beyond the scope of practice in the emergency department and should be deferred to formal radiology studies. Moving on to the bladder, you will want to evaluate it in both the transverse and sagittal planes. Starting in the transverse plane, you will place the probe just above the pubic symphysis with the marker dot pointed towards the patient's right and fan superior to inferior, making sure to pay attention to both the anechoic space within the bladder and the tissue deep to it for any evidence of free fluid in the pelvis. Depending on the gender of your patient, you may also notice seminal vesicles and prostate or vaginal stripe and uterus. The transverse view of the bladder is perhaps the best view to evaluate for ureteral jets. While sometimes seen without Doppler, it is typically easier to turn on color flow to look for the burst of movement shooting across from the deep side of the bladder wall. Keep in mind the presence of jets does not rule out a partial ureteral obstruction. Once you have completed a full sweep of the bladder in the transverse axis, you will want to rotate your marker dot to the patient's head and fan side to side to fully evaluate the bladder in the sagittal axis. Again, the anatomy deep to the bladder will depend on the gender of your patient. Please note a more extensive evaluation and explanation of the female pelvic anatomy is discussed in another orientation lecture. Now that you are familiar with both views of the bladder, let's move on to bladder volume. Ideally, you should look to measure the bladder volume pre and post void. As a rule of thumb, the bladder should empty to approximately 10% of the pre-void volume. Most machines will have a bladder volume calculation tool. Once you input the three-dimensional measurements, the machine will calculate the volume for you. In order to obtain these three measurements, you will need to use both the transverse and sagittal views of the bladder. Starting in the transverse view, freeze the image and measure both the AP and lateral diameters. You will then need to unfreeze the image and rotate your marker dot towards the patient's head to obtain the sagittal view. In this view, you will measure the third craniocaudal dimension. A volume of less than 50 milliliters is normal. Less than 100 milliliters is usually acceptable in patients greater than 65, but abnormal in younger patients. Moving on, let's look at examples of some common pathology. First, hydronephrosis. Here, an obstructive process distal to the kidney has prevented urine from draining. This backup causes dilation of the renal pelvis and compression of the renal parenchyma. On ultrasound, the space within the renal pelvis will start to become more anechoic, as you can see in this example of mild hydronephrosis. As the degree of obstruction increases, that central anechoic space will expand, while the more hyperechoic surrounding parenchyma begins to compress. Certainly, this example of severe hydronephrosis demonstrates that best. You will notice up to this point, we have not discussed ultrasound of the ureters. This is because one of the limitations of renal ultrasound is that the mid to distal ureter is generally obscured by bowel gas, making them difficult to see. However, in the setting of an obstructive uropathy, such as a large ureteral stone or prostatic hypertrophy, the ureters may become dilated and thus more obvious on ultrasound. This is a finding we call Hydroureter. In this slide, the top two images show examples of proximal ureteral dilation, while the bottom image shows evidence of a more distal obstruction. In this video, we have an example of a renal stone. If you look just below the yellow arrow, you will see a small hyperechoic stone with some posterior shadowing. A much more obvious example is this bladder stone, likely sitting at the urethral opening. Here we have an example of prostatic hypertrophy. While it may look like a potential mass sitting within the bladder, if you look carefully, you can actually see the prostatic urethra traveling through the ventral surface. Ultrasound can also be handy if you want to evaluate the placement of a Foley catheter. Once inflated, the Foley balloon will appear as a hyperechoic ring with an anechoic center being transversed by the bright Foley tubing. If draining appropriately, the bladder should quickly decompress around the balloon with little anechoic urine left to evaluate. Approaching the end of our lecture, we will touch briefly on the appearance of renal cysts, as they are not an uncommon finding on point-of-care ultrasounds. Most cysts we see are simple, uncomplicated cysts. These will appear as well-circumscribed anechoic collections along the periphery of the kidneys without any septation. Compare that with this slide of polycystic kidney disease with clearly more complex appearing cysts throughout the kidney. Lastly, in the right clinical context, the appearance of more hyperechoic regions within the renal parenchyma should raise concern for possible hematoma, which is typically less well defined with a mixed echogenic appearance, or mass, which is often more well defined and homogeneous. With that, I thank you for your time and hope you found this lecture helpful. Please bring any questions you may have to our hands-on session during orientation.